everyone. Thank you for joining us tonight. It's my pleasure to be here, introduce you to also my co-chair in a second. This is a session titled Contemporary Insights on Diagnosing and Treating Transthyretin Cardiac Amyloidosis, How I Think, How I Treat. And thanks to the peer review team who helped us put this session together as well. And so my name is Ahmed Masri. I'm a cardiologist at Portland, Oregon Health and Science University. And I'm glad to be joined by Dr. Natasha Sarswat, who's at the University of Chicago. And again, would like to thank peer review for providing this session. BridgeBio Pharma did provide educational grant for this symposium. If you haven't already, please complete the pre-event survey, and then a reminder to look out for additional polling during the presentation. So we're going to be using, phones in this scenario. We're going to sometimes ask questions and do some polls there, so keep that handy. And then you can submit your questions. We're going to have a Q&A by the end. And then for the in-room learners, please use your personal device with a QR code. And then we would like also to welcome our virtual learners. So please, you can respond to the polls on your screen and enter the questions also in the chat. And so this is, there is a $50 gift card here, and there are some instructions on how to complete the survey and then answer the polling questions. And so the event, you can have more information about it at this website. This is a QR code that you can also scan. So these are our goals for today. So during this presentation, we will learn that ATTR amyloidosis is not a rare disease as once thought before. We do need a high index of suspicion, though, because it can be presented with valid presentations. Monoclonal protein screening is essential for the accurate, non-invasive diagnosis of transthyretin amyloidosis. And then targeted therapy for ATTR cardiac amyloidosis slow the disease progression and are most effective if initiated early in the disease course, since on average we can't reverse the disease course. And so I will hand it over to my co-chair to take us through the first part of this, which is an introduction to transthyretin cardiac amyloidosis.
All right, good evening, Natasha Sarswat. I'm one of the advanced heart failure transplant cardiologists at University of Chicago. I'll be starting with an introduction to ATTR. So first, let's talk about what amyloidosis is. Cardiac amyloidosis is when a protein can infiltrate the myocardium, generally causes a restrictive cardiomyopathy. There are two main kinds of amyloid that affect the heart that we see most frequently. Number one is AL amyloidosis, which is a light chain problem where the bone marrow secretes these light chains. The second type is called TTR. The transthyretin protein, or TTR protein, is created by the liver. There are two different types of TTR. That's the hereditary form, caused by a variant in the DNA that creates hereditary TTR, and wild type, which is generally thought to be a process of aging. Now, the different types can present differently. AL tends to be very systemic, can definitely cause a neuropathy, a nephropathy. GI involvement less commonly causes orthopedic issues. The variant type can cause certainly a neuropathy, more depending on which type of variant. It can cause GI involvement as well as orthopedic issues that we'll discuss, such as carpal tunnel and spinal stenosis. Wild type TTR tends to cause neuropathy, can cause GI involvement, and certainly we do see a lot of orthopedic issues. So again, the transthyretin protein is a protein predominantly synthesized in the liver. It is a transporter protein. It does carry around vitamin A via the retinol binding protein, and it can carry around the thyroxine protein as well. It's also made in the choroid plexus, secreted in the CSF, and is the primary transport protein for thyroxine and retinol. Lots of times we'll call it prealbumin, and as we check it normally in clinic, we're often referring to TTR levels when we look at prealbumin levels. When we talk about the hereditary form, you might hear us kind of flip back and forth between different types of nomenclature. So the V122I or V122I variant is the most common in the United States. You'll also hear it called the V142I, and really it's just adding 20, but all of the variants you'll hear referred to differently just based on that 20, but it's the same genetic variant. Okay, so let's kind of walk through the different kinds again of amyloid. So first, let's start with wild type. Wild type tends to occur in people over 70. It is the most common in the United States. There is certainly a male predominance over females, though I think certainly there's a sentiment that women are underdiagnosed. We tend to see in the United States, the wild type tends to happen more in Caucasians than in blacks, and we always see cardiac involvement. We can get neuropathy, interestingly enough, in up to 22%. We do see carpal tunnel syndrome as well, very commonly. Next, we're going to talk about some common types of variant or hereditary TTR. So the V122I is the most common form of hereditary amyloid that we see in people generally over the age of 65, particularly when it's heterozygous. There is 1-to-1 male-female in the genotype, though the phenotype tends to be more in males than females. We see this in the United States, again, in Black or Caribbean, people of Black or Caribbean descent, West African ancestry, and certainly in some Hispanics. And this is in about 3.5% of African American or Black patients. Again, that's the genotype, not necessarily the phenotype. We do certainly see a cardiomyopathy, and in V122I, we tend to see a more severe cardiomyopathy by age 75, and we can also see neuropathy, carpal tunnel as well. 1M, I68L, and those often tend to cause more cardiomyopathy phenotypes as well. You can see the listed kind of races and nationality, and then we see a couple of different variants that cause what we call a mixed phenotype, which is both cardiac and neurologic. That's T60A and V30M. V30M is the most common throughout the world. It can cause more cardiac and neuropathy. Often we see the cardiac things at a later age, the neuropathy at a younger age. So what are our manifestations? And this is part of the challenge when it comes to diagnosis. It's because there are varied presentations that can affect different parts of the system. And as we know, there's fragmented care often in clinic where different people are seeing neuropathy, different people are seeing the patients with cardiac symptoms, and we just need one person to kind of put those pieces of the puzzle together to recognize and have that index of suspicion that this could be amyloid. So from a cardiac manifestation standpoint, we certainly see heart failure. We can see atrial arrhythmias like atrial fibrillation, atrial flutter. We see bradyarrhythmias. We often see conduction abnormalities, and a lot of patients end up with pacemakers. Musculoskeletal manifestations that are very common, we see bilateral carpal tunnel syndrome, and it's to the point that we are screening and engaging our orthopedic surgeons to look for amyloid in patients with bilateral carpal tunnel syndrome. Back pain is very common, and we see lumbar spinal stenosis. We often see ligamentum flavum thickening on spinal MRIs. Ruptured distal tendon, distal biceps tendon, we call it the Popeye sign, and we can often see other joint pain. Trigger finger is often very common as well. For some reason, amyloid really likes the hand. Polyneuropathy, we hear painful symptoms in both the hands and the feet. Often patients will describe, a burning symptom. Patients will tell me they feel like they're walking on clouds as they can't feel the ground. We often get a lot of muscle weakness as well, and certainly now as our patients are living longer, we're seeing a lot of patients that are suffering from frailty, myopathy, and falls, which is challenging in the setting of atrial fibrillation and anticoagulation. We often commonly see autonomic dysfunction, and this can be one of those clues when we're seeing patients with heart failure. That's often an intolerance to GDMT that they're being given for regular heart failure. Chronic diarrhea can also be a manifestation of that autonomic dysfunction, erectile dysfunction, sweating abnormalities, and variable blood pressure and heart rate. Okay, so here's our first polling question. What is the most common cause of ATTR cardiomyopathy in the United States? Is it the variant T60A, the variant V30M, the variant V122I, or is it wild type? Good music. All right. Yes, this was a little bit tricky. I will say I did a double take when I first looked at it too, because they start out by showing you the hereditary patient. The most common in the United States is actually wild type. The most common hereditary variant is V122I, but the most common overall cause of ATTR cardiomyopathy is actually wild type. Okay, we'll keep going. All right, so what steps can we take to facilitate TTR identification and avoid misdiagnosis? Well, first it's recognizing the red flags, right? And that's everybody here in this room to have that high index of suspicion. So this comes from earlier this week, an ACC-AHA update to the guidelines, which suggests these particular guidelines, and these are things that we see commonly. Again, from a cardiac standpoint, we often see fatigue and heart failure symptoms. Aortic stenosis, we know, goes hand in hand with this. Conduction system issues and atrial fibrillation. Those extracardiac manifestations we discussed already, bilateral carpal tunnel, spinal stenosis, tendon ruptures, joint issues, peripheral neuropathy, autonomic dysfunction. From a laboratory perspective, we'll often see troponin that's persistently elevated, and I'll have a lot of patients that may have been misdiagnosed with myocardial infarctions or myocardial ischemia that they say is demand ischemia in the past, elevated natriuretic peptides certainly. From an EKG standpoint, we often see this low voltage even when people have LVH and on their echocardiogram. Now certainly the big thing there is if you don't see low voltage, that doesn't mean that this isn't amyloid. Low voltage when you have it can be one of those clues, but a lot of the patients don't have low voltage on their EKGs. Again, atrial fibrillation is very common, conduction delays, and a pseudoinfarct pattern. On echo, what do we see? Well, certainly we see that increased wall thickness. We can see valve thickening as well from amyloid deposition. Pericardial effusions are very common, biatrial enlargement, and one of the big key things that we're looking at right now in terms of understanding amyloid is actually low stroke volume index, and that can give us a clue into response as well to treatment. We do see reduced tissue Doppler, restrictive filling patterns on the echo as well. We see a reduced global longitudinal strain, and we see apical sparing where the entire myocardium is abnormal, but the apex itself is preserved. Low gradient, low flow, severe aortic stenosis is common, and impaired left atrial strain is very common. Cardiac MR, I think, and Ahmad can talk about this as well as the imager person, but certainly I think our manifestations on the cardiac MRI here are changing. A lot of what is in the literature in terms of diffuse subendocardial transmural late gadolinium enhancement is certainly when we're picking up amyloid later. Now we're seeing different manifestations, but big clues here are also an increased T1 time, an increased extracellular volume, and then again, reversal of nulling of the blood pool are very common things we'll see on cardiac MR. So now just to go through how common this is, so the SCAN-MP study was published pretty recently by Rick Ruberg's group, and the SCAN-MP study basically took patients over the age of 60 that were African American, Hispanic, or of Caribbean origin that were already diagnosed with heart failure, that had increased LV wall thickness and ejection fractions greater than 30%. And interestingly, what we see is that the prevalence of TTR in these patients was about 10% in men, and you can see about 10% in African Americans. And when we look at people over the age of 75, we're up closer, higher than 10 to 15% of these patients just randomly doing PYPs on all of them without even any of those red flags actually were patients that had TTR cardiomyopathy. Now, when we look at just the black patients, out of all of the men, about 10% of them, again, actually had TTR. If you look at those patients that are greater than 75, we're up in the 15% range. And then we're looking at men over the age of 75, we're up closer to 20% of people. So again, these are African American men greater than 75 who have heart failure and mild, just even an LVH greater than 1.2, up to 20% of them were actually amyloid patients. So just to kind of hit home on some concomitant cardiac diagnoses, certainly aortic stenosis is something that we see, conduction disorders, patients going for TAVR, Not all of our patients have preserved ejection fraction. Certainly there are a good portion of them that are half-ref patients as well. We do see often patients that were told they had hypertrophic cardiomyopathy and actually end up being amyloid patients. Patients in the HFpEF population, we think about 13% of them are actually amyloid patients. Okay, so now we went through kind of the red flags, suspicion, and we recognize that this is actually very prevalent. How do we figure this out? So this is an algorithm that I think all of us use. So number one, we got to look at the clues from what we talked about, the red flags, the history, the EKG, the imaging. And then next step is, do they have a monoclonal protein? We want to rule out AL amyloid. So that should come before, thank you. That should come before anything else. Basically, we're doing a serum and urine immunofixation and immunoglobulin light chains. If any of those are abnormal, then we're going down the left side of the screen and we're having discussions with our hematologist. And this is where that multidisciplinary part of the treatment and of the diagnostic part really comes into effect, because this is, direct discussions to get patients quickly diagnosed. And then we're going to biopsy the affected organ, which is often the heart. Important thing, when we do biopsy, that tissue has to be sent for mass spectrometry to understand if this is AL or TTR. That'll look at the proteomic conformation. Okay, so now we're going to go down the other side, assuming that there is no monoclonal protein, assuming that the light chains and the ratio is normal. What do? Most patients now, about 80%, go down this way and are diagnosed non-invasively. And that's where we look at PYPs or DPDs with SPECT. Patients that have grade 2 or grade 3 uptake, that we say, okay, you have ATTR cardiomyopathy, then we need genetic testing, which differentiates the hereditary from the wild type. If the PYP is negative, and your suspicion is still very high, there still is very much a role for biopsy in there. If your suspicion is low and we're not seeing those other red flags, you don't have other imaging to worry about it, then you can say, okay, this is less likely amyloid. Important when we look at the light chains, and I just want to kind of point your attention to the upper right part of the screen here. We're looking at not just SPEP and UPEP, we're actually looking at immunofixation, which is much more sensitive from monoclonal spikes. And then when we're looking at the light chains, we're looking at that light chain ratio. And the note here is that this can change with renal function. So often we'll see patients that have some level of CKD, they'll have abnormal light chains, and everybody will say, oh, this is not somebody we can go down the PYP route, this is somebody we need to biopsy, but important to take that into the context of the GFR. These may still be patients that we can go down the non-invasive imaging route. A couple other things to note here is that SPECT and CT imaging is imperative to exclude blood pool. And then again, if you have patients that your suspicion is still high enough and their PYP is negative, still there is a role for biopsy there. Okay, so the non-biopsy diagnosis of TTR, let's go through kind of the 4 main things. So appropriate clinical suspicion, we've talked a lot about, a lot of those red flags. You can get some sense of demographic clues, again, if the patient is older or if they have a family history or based on ethnicity as well. Characteristics on imaging, we've talked a lot about, both on echo and cardiac MR. And then the next step really, again, is that scintigraphy. Note that we cannot diagnose right now amyloid, and we cannot say definitively just based on MRI findings. We really do have to move to the next step, which is either biopsy or cardiac scintigraphy. And again, that has to be in the absence of a monoclonal protein to make that diagnosis. Okay, now we've gone through diagnosis. Let's go through the next polling question, which is, in a patient with suspected ATTR, which test is optional? So this is a little bit more divided here. So when we go through our diagnostic algorithms, certainly EKG, monoclonal protein screening are imperative. Nuclear scintigraphy, again, if the monoclonal protein is negative, an echo certainly can give us clues. The one here that's optional in the role that we're still really understanding is cardiac MR. I do personally think that there is a big role both in diagnosis and treatment and certainly differentiating patients that have increased LV wall thickness, but in that actual diagnostic algorithm, it's not a necessary part to make that diagnosis, and we are not yet at the point that we can make that diagnosis purely on cardiac MR. Okay, I'm going to hand it over to Ahmad.
All right, thank you. So we're going to have, in between all of these things, we're going to have some few cases to go over so that, one, we can get you to think a little bit more about how one sees these patients, but also have some discussion as well as we go. So this is a very typical presentation in a heart failure clinic, which is a white male patient, 81 years old, coming in with some symptoms. And, the first thing, the previous question, some of you chose EKG, but the reality is it's near universally impossible to make it to a cardiology appointment or having suspected like someone coming with dyspnea or with leg swelling or something and not get an EKG and an echo. It's just near impossible, essentially. Because ultimately, you want to rule out arrhythmias, conduction disease, any of these issues. And, this EKG really doesn't tell you much. It just tells you that there's some conduction issues. And, but it's important to pay attention to it because I'll show you next the echocardiogram. And, not all of you are used to looking at echocardiograms. So what happens here is that this is called the parasternal long axis view. And you have really significant thickening of the ventricle. The septum can be thickened in many conditions, but something that is really unique in infiltrative diseases, especially amyloidosis, is that the lateral wall is significantly thickened. And at the same time, you develop this over time that you're not having shortening of that base. It's not coming down and up and down. And so that's actually a red flag. While when you look at the short axis, it's pretty robust. So in amyloid, there is preservation of this circumferential and radial strain, but there is really large impairment of basal longitudinal strain there. And so you can see that your atria are dilated, and there's a little bit of fluid there in the pericardial space, but not much else. Now, this is actually, like in the right settings, this is diagnostic of having likely amyloid, but you can't say that because you don't know that the patient has amyloid or not just based on imaging. And that's where the non-invasive approach with scintigraphy and rule out of light chain amyloidosis has truly revolutionized how we approach this. Because, echo is not specific enough, but this is also the 5% of the patients. We want to pick up the other 95% of the patients. Let's see. And so, this is very typical case. We're not doing any tricks here or anything, essentially. The patient comes with that echo. There is absolutely no question what's going on. There is more likely than not that there is amyloid there. And so it's very, very typical to not go through other testing. You can just go and do technetium, PYP, or HDP in the United States. That's the only two tracers available for us. If you live in Europe, you can also get what's called DPD imaging. They're all essentially for our purposes the same. The planar image here on the right is actually not important. People like to look at this, but it's not really important. What's important is to look at the SPECT picture and make sure that there is uptake in the muscle. And I chose this case to show you that it doesn't have always to be like super shiny and bright. You have to make sure that you're looking at the muscle and not at the blood here or there. And so when we think about that, then you would have, for example, screened for light chain amyloidosis, which this patient actually had a monoclonal gammopathy. And we typically end up doing our light chain testing at the same time as we do a bone scintigraphy, just for pragmatic and practical reasons. And then in that scenario, you cannot ascribe that nuclear scan to diagnose transthyretin amyloidosis. Now, the pretest probability is still above 90% TTR amyloid, but we don't want people to miss the one patient out of 20, 30, 40 who could be AL. Why? treatment is totally different, and that patient will be dead if we just put them on a stabilizer or a silencer. And so that's why we go for an endomyocardial biopsy. In this scenario, a fat pad biopsy is not sufficient. An extracardiac biopsy in the scenario of a typical amyloid-looking disease in an older individual with a positive nuclear scan and monoclonal gammopathy is not sufficient to do extracardiac biopsy. You have to go to the heart. And so you do endomyocardial biopsy, and you diagnose the patient, and then you typically do gene testing, even if the mass spectrometry can tell you that the sequence of the peptide is normal or abnormal. It still misses rare variants sometimes, and so we prefer that you end up doing gene testing as well there. And also in this scenario, we end up discussing treatment options, which I'm gonna wait and not ask you about that because we're gonna have some more talks first about that, and then we can talk about how would we treat such patients.
All right. So, nice handoff. We'll start talking about contemporary treatment, and this has obviously changed dramatically in the last 6 years. So before we get into what we call disease-modifying therapy for amyloid, let's talk about regular heart failure treatment, and this is something that we're still understanding. The role of beta blockers here. So a lot of our patients end up on beta blockers because they have concomitant atrial fibrillation. Right now, we don't have any clear evidence that there is benefit to beta blockers on these patients. Most of them tend to be poorly tolerated. If they are on them, we often try to do a less vasodilating version of them, even if they have low ejection fractions. And unlike my other patients with low ejection fractions that I'm trying to ramp up their GDMT and increase their doses, this is certainly not what I'm trying to do with our amyloid patients. Similarly, from the ACE, ARB, or ARNI perspective, we do not have any clear evidence that there is benefit even with low ejection fractions. And certainly a lot of these patients will not tolerate and will be over vasodilated and will have syncopal episodes and worsening orthostasis. So there is right now not any clear role for any medications in that class. Now there is some small data that does show actually a mortality benefit for MRAs in these patients as well as SGLT2s. Most of that data is retrospective. Certainly those two classes of medications are ones that I'm trying to get on to all of our patients with amyloid in the clinic. Certainly if they have atrial fibrillation and we are giving them an anticoagulation, regardless of their CHADS VAS score, that does not apply to these patients. They are very hypercoagulable, and there is a lot of active research that you'll see here even at AHA right now looking at other ways to identify which patients with TTR cardiomyopathy need anticoagulation. And a lot of those patients are even patients that are in sinus rhythm that potentially have electromechanical dysfunction. So anticoagulation is certainly something that we are very much pushing on anybody with atrial fibrillation. These are ones that I tell patients don't let anybody stop it unless our backs are up against a wall. Okay, now let's talk a little bit about disease-modifying therapy. So I think one really cool thing about amyloid is that the pathophysiology, the biology here, really has fed into the treatment. And you can really rationalize, and I often show these pictures to our patients so they understand where our treatments are targeted and how they're making a difference. So again, we talked about how the transthyretin protein is made in the liver. That transthyretin protein is a tetramer. I always tell patients it's like a four-leaf clover. That four-leaf clover falls apart into one-leaf clovers, or those monomers. Those monomers then are misfolded and form oligomers again that form the amyloid fibrils that deposit in lots of places. So where can we target things with treatment? So first, we can prevent the actual TTR production. We can do that with liver transplant, though the role there has really gone out the window. We can do this with gene therapy. So the active magnitude trial looking at NextZ is a CRISPR-Cas9 editor where we're trying to prevent TTR production. And then we can look at silencers. So there are 3 silencers that are FDA approved for the hereditary neuropathy. And vutrisiran really in March of 2025 was also approved for cardiomyopathy. These work by, again, preventing TTR production prior to that tetramer that is created. Then we have what we call stabilizers. These stabilizers essentially keep that protein in a four-leaf clover. This is tafamidis that was FDA approved in 2019 for TTR cardiomyopathy, both wild type and hereditary, acoramidis, which was also approved about a year ago, and diflunisal as well, which we often use off-label as a stabilizer. Then in investigational, we have several amyloid fibril degraders that actually phagocytose and can eat up the amyloid and have potential to cause reversal. Again, these are investigational and are ongoing clinical trials. Okay, so just to walk through kind of mechanism of action of the three medications that are FDA approved for cardiomyopathy. This is for both wild type and hereditary. So number one, tafamidis, again, FDA approved in 2019. This basically binds to one of the thyroxine binding sites. It is an oral tablet. It's taken once daily. You do not need any vitamin A supplementation. It does not have it has a cardiomyopathy indication, but not a neuropathy indication in the United States. Essentially, really no side effects. In the clinical trials, the adverse events were more in the placebo than they were in the patients themselves. And the only warning is for women that are pregnant that it can cause fetal harm, which we're not really seeing. The second drug is called acoramidis. This, again, was FDA approved about a year ago. This, interestingly, was created based on a gene variant, a TTR gene variant that is protective called T119M. This is a naturally occurring gene variant in TTR that actually protects patients from cardiac disease, separate from amyloid. These patients live longer and have less overall cardiac adverse events. So the drug actually mimics that variant. It stabilizes the TTR tetramer in 2 spots. It is an oral tablet. It is a twice-a-day drug rather than a once-a-day drug. We do not need vitamin A supplementation. It is FDA approved, again, for cardiomyopathy, not for neuropathy. We do see it reported in some of the data, some diarrhea and abdominal pain that can happen and is rare. The third drug is the first silencer that was approved for cardiomyopathy, which is vutrisiran. Vutrisiran is a sub-Q injection every 3 months, generally done in an infusion center. I've had very few patients that have been able to do it at home. How it works is by binding that to that hepatocyte receptor and then prevents the mRNA translation so that the TTR protein is not made. We do need vitamin A supplementation. As we talked about, the TTR protein is a transporter protein of vitamin A. It is FDA approved in the US for both cardiomyopathy and neuropathy. There are really no common adverse events beyond some joint pain that some patients can report. And again, the vitamin A issue, what we recommend is that patients take the recommended daily allowance of vitamin A. Okay, so just to kind of talk through the data, we're going to start with tafamidis. So tafamidis was studied in the ATTRACT trial. This was published by Matt Maurer in 2018. This was 441 patients, both wild type and hereditary. Patients either received 80 milligrams or 20 milligrams of tafamidis, and they were compared to placebo. What we saw is a significant mortality improvement. That benefit held at 18 months. The issue with a lot of these patients is that initially there was a sense that the patients with NYHA class 3 did not benefit, and long-term data that has not borne out, and actually even the class 3 patients have seen considerable mortality benefit. We do also see a decrease in morbidity in terms of heart failure hospitalizations, improved 6-minute walk, and improved KCCQs. This is a number needed to treat of 7.5 to prevent 1 death in over 30 months, which is very impressive. This was a game changer in our therapy and our ability to offer this to our patients, but certainly was done in a time when we were picking up amyloid much later and patients were more ill than they are in current modern day. Important to note that the SGLT2s, this is more recent data that just came out looking at SGLT2s with tafamidis, and we see the benefit regardless of whether or not they're on tafamidis. The SGLT2s can potentially lower mortality. There was a study through Trinetics, which I thought was interesting, that was just recently published, looking at some of that GDMT that we talked about, and even mentions that there's potential for Entresto to help these patients. Again, this is retrospective, small amount, is not borne out, and is not something that I would at this point recommend. And then just to give a shout out to a few studies that are here with more data coming out through AHA. Okay, now to turn to the ATTRibute-CM trial. This is where we studied acoramidis for cardiomyopathy. This was a phase 3 trial of patients receiving 800 milligrams of acoramidis versus placebo. The majority of patients, just like the ATTRACT trial, were wild type. The majority of the patients were also men. Patients were not allowed to be on tafamidis during those first 12 months, but then if the investigator felt like they wanted to drop them into tafamidis, once it was FDA approved, they were allowed to do that at the 12-month mark. About 17% of patients did receive tafamidis, and both of these trials basically used the Finkelstein-Schoenfeld method, where it has a hierarchical analysis where mortality is the first kind of thing, where you compare placebo patient to a patient on drug. If one wins, one wins or doesn't win, then it goes to the next thing, which is heart failure hospitalizations and then quality of life. And what we saw is that patients that were on acoramidis basically had a significant improvement in all-cause mortality, CV-related mortality, as well as time to first CV-related hospitalization. And we saw this both in the hereditary and the wild-type patients. Dr. Masri, standing next to me, published this, where we looked at cumulative CV mortality or recurrent CV hospitalization in an exploratory analysis of the ATTRibute-CM study, and basically showed that patients acoramidis versus placebo were less likely to be recurrently hospitalized or to have recurrent cardiovascular hospitalizations, regardless of wild type or hereditary again. And then when we look at subgroups, so this just came out today, I believe, where we actually looked at specifically the V122I population. Again, that gene variant that's in about 3.5% of African Americans, and it is the most common cause for hereditary TTR in the United States. We saw a significant improvement in that subgroup, which is very telling and very important as we discuss this treatment with our patients. Okay, so those are the stabilizers. Now we're going to move to the silencers and look at the data for vutrisiran. So vutrisiran we studied in the HELIOS-B trial. This was 655 patients with TTR cardiomyopathy. Patients were randomized 1-to-1 with vutrisiran or placebo. Again, this is a sub-Q injection every 3 months. The primary endpoint was a composite of death from any cause and recurrent CV events. We saw an improvement in mortality overall, death from any cause, and time to first event in the population. Important to note that about 40% of patients were on tafamidis at the time during the study, and we saw the benefit of vutrisiran even in the monotherapy, so we cannot say that the improvement in mortality was because of patients on concomitant tafamidis. Interestingly, we have seen some cardiac structure data with vutrisiran, which I think is very interesting, which basically we were looking at on the cardiac MR data, we see a sense of, and in very small numbers, of potential regression of the amyloid deposition in the myocardium with vutrisiran. We see an improvement in left atrial strain and in RV free wall strain as well. And again, I think that's particularly interesting because all of these medications that we know of simply slow progression and have not been shown to cause reversal. Again, it's preventing the protein from being made. So how are we seeing improvements? There are a lot of theories regarding clearance. Do these medications also improve clearance, and is that what's causing actual improvements? We also see improvements in renal function in a lot of these patients, or lack of worsening of renal function. in a lot of these patients, and that's potentially from, again, increased blood flow, increased stroke volume that's getting to the kidneys as well. And then there is a vutrisiran healthcare resource utilization study that is coming out on Monday that will be here at AHA as well. Okay, so now we talked about the three main trials that are contemporary. That's the ATTRACT trial, the ATTRibute trial, and the HELIOS-B trial. As we compare them, we note that all of them largely had patients in the upper 70s. They were male predominant, about 90% of patients in all of those trials, and Caucasian predominant in the 80s for all of them. The majority of them were wild type as well. What we do see a difference in really is the NYHA class. So if you'll note again, the ATTRACT study, the majority of patients still were NYHA 1 or 2, but they had 30% of patients that were NYHA 3. Whereas in ATTRibute and HELIOS, the majority of patients really are NYHA 1 and 2, and a much smaller volume of patients that were NYHA 3, again signifying that these were a healthier group of patients because we're catching them earlier. NT-proBNP was also at baseline, higher in the ATTRACT trial and the tafamidis trial, and NAC staging, which is basically NT-proBNP plus EGFR. NAC staging also was higher in the ATTRACT study, meaning again, a more ill group of patients. On the right side, what you see is kind of a sense of those trials that are overlapping. And what we do see, and the important thing here is to understand that, yes, mortality is improving in all these trials, but it's also improving in the placebo groups, which means, again, that we're catching these patients earlier, so they are living longer. So difficult to compare all of these drugs, and none of them were compared head-to-head, and all done in a little different era. Okay, so now we talked about the treatments. What do we do from here? We put somebody on a treatment, and what do we do with them? So prior to this, we really had one drug, and patients would say, well, what else have you got for me? And I said, well, you're here, you're not in the hospital, you're alive, and you're here with your family, that's what we got. But now we have options. How do we decide, how can we monitor these patients? How do we show them whether or not a drug is working, and how can we look? Truthfully, we don't really understand disease progression, right, and how we can monitor. There are some suggestions. So Dr. Garcia-Pavia published this a few years ago, and I do like this, and I think it makes a lot of logical sense. So basically, we divided methods of progression into kind of three categories: clinical and functional, biomarkers, and imaging EKG. And if they were progressing by any one of these, that can constitute a minimum requirement for what constitutes disease progression, and may go into our thinking of changing, adding therapy, and our ways of being able to engage with our patients to understand staging. So for instance, the biomarker part, the NT-proBNP or NAC staging we've looked at, or Mayo Clinic staging are ways of telling our patients about their prognosis. Certainly from a clinical standpoint, we're looking at NYHA classes and functional quality in terms of 6-minute walks. There is some data for cardiopulmonary exercise testing that we're all evolving as well. From an imaging perspective, what constitutes progression? Interestingly, what was suggested was an increase in LV wall thickness. Obviously, that comes with a lot of caveats from echo on how well the echo is done and variability there, increase in diastolic dysfunction grade, changes in systolic measurement, changes in stroke volume or global longitudinal strain. Again, here, I guess I'll say my thought here really is in the stroke volume, less so in things like diastolic dysfunction grade, because that can be something that's very load dependent and can change with time. New onset conduction disturbances can also be a marker of disease progression. Okay, this from the ATTRibute CM trial, one of the things that we've learned is that TTR concentration can correlate with survival. And what we see is in the acoramidis patients, within 28 days, often we'll see a large increase in the TTR concentration, and we know that that correlates with mortality. And we see that the earlier that happens, the better that is. I guess I'm actually presenting this tomorrow, so that was the shout out to my data that I'm presenting tomorrow at AHA as well. Okay. Now, what do we do from here? So we talked about how these different trials are very variable and how none of them have compared these drugs head to head. Where do we go from here? What do we start first? Do we add? Do we switch? What do we do? There is not a lot of guidance, is the bottom line. We don't know a lot of these answers. The ACC-AHA guidelines, again, that we were talking about earlier, that came out earlier this week, suggested this kind of algorithm. So basically what we're saying, who is too early for disease-modifying therapies? Those are patients that have the gene variant but don't have disease. Though again, we have a clinical trial called ACT Early that hopefully will help prevent disease for asymptomatic carriers. We hopefully will show that. Patients who have TTR amyloid that maybe is in the carpal tunnel or in spinal stenosis, but nowhere else, that do not have any cardiac manifestations. Those patients right now, we cannot give any disease-modifying therapy. We are monitoring them. We do serial biomarkers, echoes, and looking for ways to teach them about the disease to catch it early again, but right now, no disease-modifying therapy. Okay. So the middle column, who is appropriate for disease-modifying therapy, certainly anybody that has confirmed TTR cardiomyopathy, a clinical history of heart failure, absolutely, though I think most of us will treat anybody that has amyloid deposition in the heart, regardless of whether or not they've had a heart failure hospitalization, because we know earlier treatment is better, and those are the patients that do the best. From a heart failure therapy standpoint, we're often, guiding diuretics. We're again cautioned with those vasodilators and beta blockers. We use MRAs and SGLT2s, and we're learning a lot about AFib therapy, again, anticoagulation regardless of their CHA2DS2-VASc score. If you have a patient who has variant or hereditary TTR and they have cardiomyopathy and polyneuropathy, that makes more sense that their first line potentially would be a silencer like vutrisiran, because you could treat both the cardiomyopathy and the polyneuropathy, and here's where you're working very closely with your neurology colleagues to really understand if there is true amyloid polyneuropathy. Then if you have either variant or wild-type cardiomyopathy without any polyneuropathy, you could either treat with a silencer first or you could treat with a stabilizer first. A lot of that will come down to the patient discussion on whether or not they would rather be on a patient on a sub-Q injection or take a pill once a day, take a pill twice a day. Cost and insurance coverage certainly plays into that discussion. Again, there's no evidence here, or nothing in our suggestions here to suggest right now that we should be doing dual therapy with a stabilizer and a silencer. And we don't know at what point we should be changing therapies. Again, if we see those markers of disease progression, do we change? The one thing here that I will say that I think is not so much in these guidelines in that middle green column is what happens with patients with autonomic dysfunction. Those are patients, again, that I would say probably go more on the side with the silencer because we have more data for autonomic dysfunction with the silencers. Okay. The right side here is who is too late for disease-modifying therapy, potentially patients that are NYHA class 4, patients that are on inotropes that have severe kidney dysfunction, functional impairment, BNPs that are very high. Those are patients that you really want to assess if they are capable or able to get transplanted or start having those discussions about palliative care. Okay. We'll give my voice a rest and do a little, another question. So, true or false, patients with TTR cardiomyopathy should initiate and optimize all 4 classes of GDMT for HFrEF before initiating targeted therapy? Good. Yeah, again, right now, we do not have any clear evidence for improvements with beta blockers or with ARNIs, ACE inhibitors, ARBs. There is a sense that we should be putting these people on MRAs and SGLT2 inhibitors, but again, none of that needs to happen before targeted disease-modifying therapy as fast as you can. You want to get somebody on disease-modifying therapy, and perhaps simultaneously initiating the SGLT2 and the MRA, but time to treatment here is imperative. Okay. All right, to Ahmad.
All right, thank you. That was a tour de force in looking at all the data. I think, to summarize some of what has been discussed by Dr. Sarswat is that there are effective therapies. You can't compare the effective therapies head to head because there is no comparison out there. And there has been a lot of changing in the natural history of the disease. But if you really want to treat TTR amyloidosis, if you want to do the right thing for the patient, you need to really understand, I think, the data behind each drug. You need to understand the delivery mechanism, and you need to understand how it gets used, because that's how the patients are going to think about this. They're going to go to a Facebook group and think more and more about different things, talk to other people. So if you don't initiate that conversation up front with them and tell them there are, for example, in cardiomyopathy, there are these 3 options and this and that, actually they get really confused and they don't know what to do. So just think through these things, even though we don't have a head-to-head comparator trial for these therapies. So I'm going to talk about another case example here, which is someone who is 74-year-old, presented with some leg swelling, was dizzy, had multiple episodes of passing out, complains of GI symptoms, and says that, my hands and feet feel like they're on fire at night. And he's a retired mechanic and has a history of long-standing high blood pressure. So has been having a lot of progressive dyspnea and strong family history of deaths due to heart failure. And, he's actually met with many different people over the years, with 3 physicians, 2 physician assistants, and was told that his hypertensive heart disease has progressed over time and made his heart stiff. And then that the neurology symptoms were probably related to him being old and having a slightly high A1C. But he continued to think that there's something wrong. He felt really worse, and this is something really important. If the patient keeps coming back and telling you, I'm worse, hypertensive heart disease doesn't behave in this fashion. And so if you ask about surgeries, which is interesting, very few people asked him before about surgeries, like these minor surgeries. Had bilateral carpal tunnel twice, last was 8 years ago, but it was blamed on him being a mechanic in the past, and had multiple back surgeries and shoulder surgeries. So this was his exam, essentially hypotensive, volume up, overloaded, and had some issues with neuropathy or nerve testing as well. So when we think about, again, how we think about this is that the patient is presenting, you look at the EKG. The EKG here in this scenario shows you that, there might be some low voltages here and there, but they actually do not meet the traditional criteria. And people try to get low voltage in all leads of the EKG. You don't need that. You just need essentially 2, 3, and AVF to have less than 5 small boxes. So that's essentially your really limb lead low voltage EKG, which is so much more sensitive than looking at the precordial leads necessarily. And so in terms of labs, creatinine was 1.3, NT-proBNP elevated, and then troponin as well. TTR or prealbumin was 14. This lab has a normal range between 20 and 40 milligram per deciliter, and then kappa, lambda were normal, and then there was no monoclonal gammopathy. So from an echocardiographic perspective, I don't know if this is going to play or not, maybe not, but there is diffuse hypertrophy both in the septum and the lateral wall. And then if you have access to strain imaging, which is what you're doing with strain is just you're encoding how these walls move. And so you get, here is the apex of the heart or the apical segments represented by 5 segments. Then here is the mid sections of the heart, which are here and here. And the ones outside are the bases of the heart here and here. And red is good and the rest is bad. And you can actually change the colors if you'd like. And so that's what's called relative apical sparing or cherry on top approach, which is signaling that there could be, it's not diagnostic, there could be infiltrative disease going on there. And if you look at the bone scintigraphy, this is slightly different from what I showed you before. This is very, very clear, classic example of highly, highly positive test where you have diffuse uptake, RV and LV in the myocardium there. Again, you don't really need this picture, and this is not sufficient. You have to go for SPECT imaging. And so every patient who complains of neuropathy, we usually end up referring them to one of our neurologists, but also end up doing nerve conduction exam. And the patient had mild chronic length-dependent symmetric axonal polyneuropathy, which just simply means that they have, they start from down in his legs and coming up, that he's having these symptoms, a combination of some sensory and some motor dysfunction. And as we saw from the symptoms, he also has autonomic dysfunction. So all of these together are what constitutes polyneuropathy. Just having tingling or numbness in your hands or feet, that's not polyneuropathy. So you have to understand how we studied these drugs. They weren't studied for just tingling. And the patient underwent TTR gene sequencing, which showed the V122I mutation. He's also Black, and so that fits kind of in the case here. And since you've heard about a lot of the different treatment options, I'm going to ask Dr. Sarswat, from the treatment options here in terms of the cardiomyopathy and the neuropathy, how do you nowadays think about these patients and approach them?
Yeah, so I mean, we kind of talked about this in that algorithm there at the end, right? So the buzzwords for me as a cardiologist are that axonal sensorimotor polyneuropathy, which to me signifies amyloid deposition in the nerves. In addition, he has a radiculopathy too, but it sounds like he really has amyloid neuropathy, and I would, confirm that obviously with the neurologist. So if he's got both a cardiomyopathy and a neuropathy, this is where I'm probably going to reach for our silencer first line and think about vutrisiran, as first line. And I would have that discussion with the patient and say, these are our options, this is the data, this is how it goes. It's every 3 months, it's really no side effects. And
Great. So in the United States, for polyneuropathy, you only have silencers approved for this indication. Stabilizers are not. Outside the US, you have many places where tafamidis is approved for some certain stages of neuropathy. We don't have to delve into it. In terms of the phenotypes of these trials, the patients with the polyneuropathy actually had significant amount of cardiomyopathy at the same time. And so vutrisiran has a cardiomyopathy-specific trial. Eplontersen, for example, does not, but the patients who were enrolled, they could have had heart disease. Usually, you have to have only NYHA class 1 or 2. If you're advanced, you are excluded from these trials. At the same time, for the cardiomyopathy trials, you would only be excluded if you typically can't walk, which means really if you have advanced polyneuropathy. If you have some mild polyneuropathy, you could have just made it into any of these trials really with variant disease, or even, it's debatable about the wild type. And so there is really a lot of overlap. And the idea here is you need to talk to the patient and see which is the main driver of their problems. Is it the heart? Is it the nerves? And then talk to them about the different options and what's, possibly there. In reality, we don't use inotorsen and patisiran anymore. They're first generation, they have certain issues. Patisiran is an infusion once every 3 weeks. Inotorsen is an injection sub-Q every week, but it had a lot of issues related to potential rare side effects, and it was phased out from the United States market there. And so one of the issues that patients complain about is their stomach and their GI symptoms. And that's something that you really have to work hard on, and you have to try and identify a gastroenterologist in your practice who's not going to be dismissive of them. Because I've seen this all the time. The GI doctors are not interested in working with these patients since they're slightly functional. Even though they actually have an organic disease, they have functional symptoms. We still are accruing more and more data. There was some data for eplontersen. There are also some data for vutrisiran. In terms of the cardiomyopathy piece of it, there was an analysis presented last month for vutrisiran. It's a post hoc analysis looking at adverse events, showing that there was less adverse events for GI symptoms than placebo in the trial. But ultimately, really, there is no evidence for direct. You're taking patients with GI problems and you're directly comparing therapies for these patients. We don't have that. So we have to use these post hoc analysis to think about these patients. But the more important piece is the symptomatic management. Ultimately, you're going to use a TTR targeted therapy, but you really have to focus on the symptomatic management because otherwise patients are miserable. They can't leave the house most of the time. And so back to the case here, the patient was started on vutrisiran through insurance plan and had difficulties, lives in a very remote area, had difficulties coming every 3 months for an injection, even in local environment where you can get these set up. The patient doesn't have to travel all the way to the main site to get the injection. You can work to getting them the injection closer to home. But ultimately, they had issues about getting that. And so they were talked to about transitioning to a self-injection at home, which was eplontersen in this scenario. And I'll tell you what I'm showing you in this case. The prealbumin responded by going down. So remember, silencers reduce your TTR level, prealbumin, while stabilizers increase them. That doesn't mean that one direction is good and one direction is bad necessarily. That is the pharmacodynamic effect of the drug. So that's what you get to see. There is really good data in terms of increase in TTR for acoramidis as a stabilizer. There is good data relates to the outcomes as well. Tafamidis has data in terms of the magnitude of increase of TTR levels themselves. And then vutrisiran and eplontersen doesn't have a cardiomyopathy trial yet. It's going to report next year. But for vutrisiran, we don't necessarily have data on the degree of silencing and the outcomes. Maybe it's going to come out later on. And again, the GI symptoms are problematic. Why I'm showing you this case? There is no one size fits all. And what the patient chooses, actually, you would be surprised of what the patient decides on sometimes and what they complain of. We've had scenarios where the biggest issue of the patient that the insurance mandated a certain formula of tafamidis that they just couldn't take because they had some GI issues. So you had to think about other drugs. And there are, we have patients who freak out if they see a needle. And so really there are these minor things that probably no drug developer ever would think about necessarily that drive a lot of these issues. So that's why you need to know the drugs and talk to the patients, not just be in a way almost paternalistic and saying, I have this drug for you, and if you don't like it, deal with it. All right, I'll hand it back to you.
All right, so this is a common scenario that comes up of how do we manage AFib. AFib is so common in our amyloid patients that if it's not there, I go looking for it. And I'll say, a group of us were at the national meeting of the amyloid support group a couple of weeks ago, and in our breakout sessions, I would say the number one question that we received is, what do we do about my AFib? Should I get an ablation? What do I do? What medication is going to help? And this is a challenge. All right, so let's first, I guess, talk about the prevalence of atrial fibrillation, and we can look at the different trials. So the number of patients with AFib in ATTRACT, again, that's where we studied tafamidis, was 71%, very high. In ATTRibute-CM, 60, and in HELIOS-B, about 60. How were those patients treated? And again, this is just looking at the data. We don't know were they on beta blockers for that reason or what was happening, but certainly we saw that a lot of these patients were on beta blockers. The number of people that were on anti-thrombotic agents, interestingly enough, in the tafamidis trial was actually only about 40%, which does seem low given that there were 70% of them that had AFib. And then in APOLLO-B, where we studied patisiran, it was about 80%. A good portion of them, again, can get pacemakers. The role of defibrillators here is extremely controversial and not been well studied. Certainly for primary prevention, there really is no data, even with a low ejection fraction. Potentially for secondary prevention, there is a role, but still quite a data-free zone here. So we know that AFib correlates with mortality, and when we look at the ATTRACT trial on which patients had AFib, that portended a worse prognosis, and essentially that we see that those patients with AFib, regardless of their treatment, still did worse, is the bottom line here. What we do see is that acoramidis has some data, and this was a study that Brett Sperry presented at HFSA just a few months ago, looking at the results of acoramidis on what happens with the EKG. And we saw that acoramidis decreased the risk of worsening PR intervals or QRS durations relative to placebo. What that really means in the big picture, we don't understand yet. Does that worsening PR interval certainly signify the concern is that they are having progression again in conduction system disease, and can treatment prevent them from getting a pacemaker? And this was just presented, actually some of it was today even, and I think there's another presentation tomorrow, looking at how acoramidis handles in patients with atrial fibrillation. And the bottom line is that even with patients in atrial fibrillation, we see that significant mortality benefit, the all-cause mortality or CV hospitalization, regardless of whether or not they're in AFib. We saw that their BNPs were better, even in a good portion of them that, again, had AFib. So the data still holds. So what do we do with these patients with AFib? This is always the challenge. So we mentioned this earlier, anticoagulation again, very important, no data comparing DOACs versus warfarin, but again, we want to anticoagulate them in whatever way, regardless of their CHA2DS2-VASc score. Rate control medications, we do often use low-dose beta blockers if they're tolerated. Digoxin, I would say, is pretty controversial. We used to say that digoxin binded to amyloid fibrils and could cause dig toxicity. That has not really been seen clinically. That was based on a study like in a test tube 40 years ago, but I think a lot of us are still very cautionary with digoxin. And then certainly the consideration of pacemakers for refractory AFib. From a rhythm control standpoint, amiodarone is often a first-line agent. I've certainly had a lot of experience as well with dofetilide in these patients and tends to be pretty well tolerated. Ablation, I think there's limited evidence, but what we do all see is that you have higher success in earlier disease. So certainly if it's paroxysmal or the patient is not as advanced from the underlying amyloid cardiomyopathy, we tend to have more success with ablation. And I would say AFib versus flutter, we see more success with flutter ablations than with AFib. Interestingly, there was one retrospective study looking at left atrial appendage closure devices and did show that it was a reasonable alternative to reduce bleeding complications. I will say I personally have put Watchman's or other left atrial appendage closure devices in a handful of my patients. But again, that's when my back is up against the wall, when these patients are falling and hitting their heads, and I feel like it's better than nothing, but I do not routinely ever put left atrial appendage closure devices in these patients just to get them off of anticoagulation. I don't feel comfortable in that way. What we do know, again, AFib does not affect the efficacy of any of our stabilizers, and again, that we see that acoramidis has shown less of a deterioration in PR and QRS intervals in patients with or without AFib. Okay, so what is the CHA2DS2-VASc threshold for initiation of anticoagulation in patients with ATTR-CA and AFib? I think I said this quite a few times, but number one, never given. It's contraindicated to give them anticoagulation. Number two, you have to have a CHA2DS2-VASc for 2 for men, 3 for women. 3, 1 for men, 2 for women, or 1 or more for both men or women, or number 5, which is always given, there is no threshold. Okay, yes, always given, no threshold. 87% of people, woohoo. That's good.
Yeah, up from 35%. That's awesome.
All right. Back to Ahmad.
All right. Again, thanks for holding here with us. We're getting close to when we can chat about some questions and discuss some things. But I want to show you a quick case here of a Black patient, age 73, went to the ER with shortness of breath and had history of frequent headaches. This is the PYP scan, and he was saying something that he've heard the word amyloidosis before in the past, but he doesn't know which context or where and whatnot. And so going back here, one of the biggest challenges for physicians and providers who see patients who are suspected or could have amyloid is that if you don't know how to look at your own images, you're going to be tricked a lot by the reports themselves. And so you don't have to be an imager to actually do this or treat patients, but you need to identify people you trust and, in your own practice, or even outside of your own practice, that you can run less clear cases by them. So there's an example where, he was told he doesn't have anything and he should just not worry about this. But when I look at this, there is no answer in this picture because both your blood and your myocardium are essentially lighting up. You actually have no idea what is going on here. So this is a useless test. This is not positive and not negative. And we still don't know why some patients have really delayed uptake into the bones and emptying of the LV cavity, the blood pool. We don't know why. So if you look here is the expected blood pool of the LV, and here is the expected septum and lateral wall. And again, you don't know what's going on there, really. And so that's why, we've transitioned in our practice a while ago because of repeated deficiencies and lack of access to PYP into HDP. And I really grew to loving HDP because what happens with HDP is that it gets taken up to the bones very quickly. And so you end up with really crisp pictures. And so I told him, I think we should just biopsy you. And he's like, no, I don't want to really get biopsied. Can I do something else? I said, let's do this repeat scan at our shop and maybe we can get nicer pictures, which we did. And the problem is that the guidelines tell you, which is appropriate, that only grade 2 or 3 uptake are abnormal, which means, or diagnostic of TTR. Any uptake is abnormal, but only 2 or 3 are diagnostic in the absence of AL. So what happens here is that your LV cavity is fine, but you do have some uptake, which is very faint in your septum. And so you have one of two options here. Either you just dismiss the patient, or you remember that any degree of uptake is abnormal, but you cannot use this mild uptake to diagnose the disease. You do need secondary confirmation. And so, what I teach the fellows at our shop is very simple. If you have classic findings, you're done. Treat patients. If anything is less classic, meaning either you have patchy uptake, or you have faint uptake, or even you have negative test, but you have high suspicion, you need a secondary confirmation. It doesn't have to be a biopsy. If you can do an MRI, that's fine. And this guy happened to have a device, so I didn't, we have a long wait time for devices with MRI, and so we didn't want to do that. And also the other problem is that you might not have coverage from the insurance or the payer if you don't have a confirmatory biopsy, even if your CMR is positive. So you might not have coverage for the drug. That's why we went with biopsy in this scenario, and obviously the biopsy confirmed that the patient has transthyretin amyloidosis with mass spectrometry. The other thing that happened is that the patient also had recurrent paroxysmal atrial fibrillation. This is a big change from 10 years ago, 8 years ago, 7 years ago, because we now can treat these patients. We're so aggressive in managing their conduction disease and their atrial fibrillation. So we do a lot of ablations. If you're really on the older side or a lot of comorbidities, we do a lot of amiodarone in these patients. If you're on the younger side and have healthier kidneys and whatnot, we do dofetilide or sotalol in some of these patients, but that has to be done very, very carefully because there can be some issues there. And so this is an example of a patient where we spoke to about the different options available, including no treatment, by the way, because while he's having some symptoms, he doesn't have clear findings similar to the clinical trials. Now, sometimes you just have to use logic. Nobody needs to fit every clinical trial criteria that we've ever seen to be on therapy. This patient has biopsy-proven amyloid in their heart. Why would I wait another 2 years until they start to develop heart failure? I wouldn't. And so I spoke to him, and after some discussion, we talked about what to be on. And this is an example where he was on a very high dose of rosuvastatin. And we've had some cases where this was before even vutrisiran was available, so we didn't have that discussion with him. But we have had cases of tafamidis interacting with rosuvastatin You can read about that if you'd like. There are some cases online as well about this. And so we spoke to him and, about the options, and, he was started on acoramidis, and, he's been on it for more than a year, not a single, worsening of symptoms or anything. And that's, I think, the key point for the future, which is if we find these patients early, everything will be different because you can stabilize or silence the disease, the protein, and more than not, these patients are not going to progress. And so that would be the key point, is try to find these patients on the earlier side. All right, so what does the future hold for us in the last few minutes that we have? You've already seen this. This is the pathophysiology of the disease. We talked about the available silencers. Eplontorsen is an antisense oligonucleotide that silences TTR or knocks down TTR. It's once a month injection, self-auto-injector, can be done at home. The CardioTransform trial will report next year, most likely. And then we have gene editing, which is using CRISPR-Cas9 technology. It's permanent gene editing. It's thought to be one and done in a way. We have data up to 3 years that show that you continue to have low TTR levels, and you can redose patients. They had, I think, 2 or 3 patients who got redosed after a lower dose of the drug. And this trial is ongoing. So this is all investigational that I'm talking about. None of it is approved for use for cardiomyopathy. Eplontorsen is already approved for the use for polyneuropathy. We talked about vutrisiran and patisiran. And then in terms of stabilizers, there is another one that we didn't necessarily talk about, which is diflunisal. It's available, but it's not approved for this indication. And it doesn't make any sense if you can get a patient on a drug that's proven to actually work and effective and doesn't have side effects to go for a drug that is a non-steroidal that is not essentially approved for this indication to work. And so I personally rarely reach out to diflunisal, if any. And then the other group of drugs are doing something different. They're trying to go after the organ and remove amyloid from the organ. That's what we call them, the fibril depleters or fibril removers. And there are 3. There is the Alexion 2220 or cliramitug, and there is coramitug, which is NN6019, and then there is ATO2. And so this are all under investigation, and what happens is that they try to recruit more macrophages to come to the organ of choice. Here in this example is the heart, and we want to try to incentivize our immune system to remove these fibrils. And so if you follow the light chain literature, there's been few disappointments lately in the light chain literature, but here we're still learning about them in TTR. The phase 3 trial depleter using the ALXN 2220 is actually fully recruited, and we're just going to wait a few years to see the outcomes there. And then on Monday, if you're around, you can actually go and attend the phase 2 primary results of the coramitug drug. The old name of it is PRX004, and this trial is placebo-controlled, I think close to 100-patient trial. So we should have some really good data from there. And it's been announced already that the phase 3 trial called Cleopatra is coming to a site close to you, so something to consider there. And there is going to be some updated CRISPR-Cas9 NextZ data also on Monday. All right, one of my favorite things to think about is the prevention of this disease. We know that the patient carries the variant. We know that the patient doesn't have disease. We know that the treatment is not toxic. And we know that the patient might potentially benefit if they don't develop the disease. So that's the next frontier in this condition. Can we actually prevent TTR from developing as a phenotype? So this is called ACT Early, 500 patients, 5-year trial. And patients who are carriers within a certain age and rules of expected developing the phenotype will be randomized to acoramidis versus placebo, and there's going to be an open label extension of that. So very exciting. Please, if you have patients with variant TTR who don't have disease, consider sending them, either enrolling them yourself if you're a site or sending them to some site close to you. This is really going to be an important trial for everybody and for the patients in particular. All right, so we're not going to go through this, but there's a lot of initiatives happening in this space. This is one of them, where we have the International Society of Amyloidosis trying to come up with a criteria for what are the characteristics of different tiers of centers that could take care of amyloid as a disease. This is not necessarily one size fits all, depending on where you live and how things are. So you have basic center, core center, and then center of excellence. And that is more or less just like what you should think about if you're trying to develop a center, what you think about you would want, and what are the elements there. So in terms of the key takeaways for us, ATTR cardiac amyloidosis requires a high index of suspicion to detect. It is more common than formerly assumed. You should rule out monoclonal gammopathy all the time. All the time you should rule that out. I think it's really an important thing. And if someone has heart failure in the setting of light chain amyloidosis, this is somebody who requires a diagnosis now, not next week, not next month, and you should figure out something that works for your practice, how to establish that. I can tell you what we've done. We've done a lot of initiatives locally, including if someone is really sick, we put them in the hospital. We biopsy them, we get the diagnosis, we start therapy. And so we shrink that time from many months to few days, because when we looked at our data pre-2020, half of the patients were dying while waiting to actually be diagnosed and treated. And so that's really important. Keep that in mind. And then we have many, many, many different therapies, 3 already approved for cardiomyopathy and then 4 approved for polyneuropathy. Keep that in mind as you discuss with your patients. And then this diagnostic and therapeutic landscape is really rapidly evolving. You really have to keep up with it if you want to take care of these patients. I know it's a lot. I know we spoke about different things, but it is really important. All right, and so this is the QR code, and you can also do it to, to also ask questions. We have some questions online that I'm gonna start by kicking these off, which is the first one. There's a question about what protocol do you use for a PYP study. The American Society of Nuclear Cardiology has a practice guidance of how you do this and how you can approach it. I would refer you to that. There is always like a talk of should you do it over 1 hour or 3 hours. It doesn't matter as long as you are comfortable that you're doing good imaging. You always need SPECT, preferably SPECT CT. So but you cannot do a study without SPECT or SPECT CT. I think those are the important takeaways here. There's a question here is to Dr. Sarswat. Can you elaborate on the evolution of our understanding of how disease progression happens? Meaning, over 5 years, and as more therapies are becoming available, are we seeing less progression or more progression of the disease?
Certainly, I think with our treatments, we're seeing less progression, right? And I think that's the change here, right? Especially when we catch these patients early. Patients are living long, happy, healthy lives, right? This is changing into just a chronic condition. I certainly have patients who have been on treatment through the trials for the years, and sometimes they look at me and say, "Hey doc, are you sure you got the diagnosis right? I'm doing so well," right? I think that's the key. You catch them early, they respond to treatment. I think there are a cohort of patients that we don't understand that are quote unquote non-responders that for whatever reason continue to progress despite treatment. And that's, certainly an area that we need to understand better. But the majority of patients do really well, don't progress, over years. And, when we start seeing those progressions is now when we have the ability to put them in clinical trials, to hopefully with the antifibril therapy to potentially cause reversal of disease too.
All right, great. I'm going to try to go through a few of these very quickly. In the third clinical patient, they had a grade 1 scan. They're early. What happened to their TTR level on acoramidis? Actually, I still remember that case. The question is, would you get a more robust response if you're less sick? So TTR is a negative phase reactor. If you have advanced heart failure or more progressive disease, you will have lower TTR level. And in this scenario, the patient did go up quite a lot to the mid-30s with their prealbumin. Now, the problem is that we really don't have an idea of that. If you go on a drug and your prealbumin goes up, and then you go off the drug, prealbumin goes down, and then you go on a different drug and prealbumin goes up, does that actually track with the disease itself as a progression? We don't know the answer to that. So we still need to do a lot more studies there. But that's what you would want. In my opinion, again, logic. If you're using a drug to increase TTR level, to stabilize it, increase the level, and that doesn't happen, you need to look why. And maybe we can study these patients as we go over time. There is another question here. If light chains are abnormal, like somebody has high lambda, for example, but there is no monoclonal protein, is AL excluded? And the answer is absolutely not. If someone has an abnormal light chain ratio, light chains are highly abundant, much more abundant than the monoclonal protein level in AL amyloid. That's different from multiple myeloma, where your monoclonal protein level is high. In AL, it can be totally negative in your testing. So if you have abnormal light chains, either you think through it or get a friend to help you think through it. And the other thing to tell you is that hematologists actually are not experts necessarily, all of them, in AL amyloidosis. Very few of the hematologists see AL for a living or a lot of multiple myeloma with variable presentation. So sometimes you might need to be the one who's pushing your hematology colleague to actually get on top of things and get things done. Because the other day I saw somebody who came to us, unfortunately, after 4 months of seeing a hematologist, and the hematologist has been working them up for 4 months, and the guy's stroke volume now is 20 cc's. So he's in the hospital recovering, but ultimately the point is you can't wait for too long. So there's another question here. I'm going to ask Dr. Sarswat this question. What do you think about combination therapy, especially in light of Helios-B having 40% on background tafamidis?
Yeah, I think the short answer is the jury's still out, right? I think, yes, there were 40% of patients that were on tafamidis in Helios-B that received vutrisiran, and the way it was presented is that the patients that received vutrisiran monotherapy did just as well as the people that did combination therapy. Well, the question is the reverse way, right? Did adding tafamidis cause a significant benefit? And there was not a statistically significant benefit to adding a stabilizer to the patients that were on vutrisiran monotherapy. So I certainly have patients that are on both, and a lot of those are from the era of prior to vutrisiran approval, right? When hereditary patients were on, say, vutrisiran for polyneuropathy and a stabilizer for cardiomyopathy before that data came out. Now we're in a situation, right? Do we narrow them to one therapy? And those are the discussions I'm having now every day in clinic, to say, hey, you're on both of these, you may not need both of these, and that's a challenge, right? It's easier to not add a second therapy. It's harder to take away a therapy from a patient who has been on it and has been doing well. So yeah, I still have people that are on both. I think there are patients around the country that are very educated. The amyloid population is particularly educated and invested in their care, which is wonderful. But there are definitely patients that will push us to add a second drug too when they're, say, on a stabilizer and want a silencer. And those are discussions that we're, I think, all having. I think there may come a time where we will see a benefit to dual therapy, but I don't think that we've proven that yet. And I'm hoping the plontersen trial will give us some insight into that too.
Agree. I don't think we should, in my opinion, be combining therapies before we have more data to look at this. I'll take a few of these. So any consideration for anesthesia medications intraoperatively with these drugs? No. But what you need to make sure, if you have an old school surgeon who looks at TTR level before surgery, make sure they understand that the TTR level that is very low on a silencer is not an issue, that you're causing that. Actually, this came up before.
I will add one thing there too. I have so many of these patients that are going for like hip surgeries or knee surgeries. I ask the surgeon, take a piece of tissue, and I will say I find amyloid everywhere. It is ubiquitous. And then it helps the surgeons learn as well too, and it helps understand the underlying cause too.
Great. So there was a question about NYHA class 3, despite the discouraging findings of ATTRACT. So you gotta remember that ATTRACT patients were very, very advanced, and NYHA class lacks the ability to actually measure small differences between patients. It's not like a magical scale. And so as such, I would employ logic. If the patient in front of you is literally dying in the next 3 to 6 months, don't treat them or have a discussion. But even when people looked at the 10,000 plus NT-proBNP, even those patients, 70% of them are alive at 1 year. So we have essentially a big database, 5-center study. We tried to develop a futility model it was futile to develop a futility model. We couldn't get there because you couldn't develop a futility model on for tafamidis with treatment, regardless of having a third of our patients being NYHA class 3, because you couldn't predict who's going to respond and live and who's not. As such, do not, consider patients with NYHA class 3 not candidates for therapy, in my opinion.
And again, in the extension data, the ATTRACT extension data, there was an improvement in mortality in the NYHA3. So yes, I will treat NYHA3 too.
Great. And this is one last question is, somebody got an ablation, had been on tafamidis for a while, now has really bad pericarditis, any play in terms of TTR? I think that would probably be related to the ablation, having a microperforation with some blood tracking down. You can actually prove that with an MRI if you want to, but this wouldn't be TTR. TTR is not an inflammatory condition on its own, so it doesn't really cause necessarily pericarditis, but it can cause a pericardial effusion, but without pericarditis necessarily. All right, so we're actually up on time. Thank you so much for joining us. Again, thanks to PeerView, and thanks to Dr. Sarswat.